Hello, good morning, everyone. Can everyone hear me? Are we ready to begin? My name is McKenna Byerly, and I am with the Norton CME office, and I am happy to welcome you all to our Update in Women's Health live stream event. This event, as you may know, if you've attended in the past, it's a monthly live stream program. It is the second Tuesday of the month. And our program today is being recorded and it will be available online following the program within the next week or so at nortoncme.com. Following this program, you will receive a link to the evaluation in the chat box, which Mary, my coworker here, she will be sending out the link as well as monitoring our chat. We will also display a QR code at the end of the program that you can use to go to the evaluation and to claim credit. And in addition to that, we will be sending out an email to you after the program today with a link to the evaluation and to claim credit. So to begin today, I'd like to introduce our two speakers, Dr. Kendall Stevens and Jennifer Willis. So I will start first by introducing Dr. Stevens. So Dr. Stevens earned her medical degree and completed her residency in obstetrics and gynecology at the University of Louisville School of Medicine. She then practiced locally in Southern Indiana for 8 years prior to advancing her clinical expertise in maternal fetal medicine at the University of Cincinnati. During her fellowship, Dr. Stevens developed a special interest in perinatal addiction and maternal medical conditions while conducting research in therapeutics for fetal growth restriction, which she presented to the Society for Maternal Fetal Medicine and later published in leading medical journals. This research is ongoing and may one day lead to an effective treatment for fetal growth restriction. Dr. Stevens is board certified in obstetrics and gynecology and is board eligible in maternal fetal medicine. Her unique background as a practicing OBGYN enables her to understand both expectant mothers and their medical providers while meeting the challenges of complicated pregnancies. She's happy to be returning to Louisville and committed to improving women's healthcare in the community. And Dr. Stevens has no relevant relationships to disclose. Next, I'll introduce Jennifer Willis. Jennifer, as she goes by Jenny. So Jenny earned her Master of Science degree from the University of Louisville, as well as a Master of Science degree in nursing education from Bellarmine University. She has practiced in Southern Indiana at Clark Memorial Hospital since 2010. She has been a certified diabetes educator since 2005 and joined Norton Healthcare as a nurse practitioner at the Maternal Fetal Medicine, Diabetes and Pregnancy Center downtown location in 2012. And Jenny has no relevant relationships to disclose. And with that, I would like to introduce our speakers officially with video, Dr. Kendall Stevens and Jenny Willis. So thank you both for being here today, and we look forward to your presentation. And again, any questions that you have for the speaker, please enter those in the Q&A section. You can see that at the bottom of your screen, and we will address all the questions at the end of the program. And if you have any questions logistically, please enter those in the chat, and Mary, my coworker here, will be monitoring those as well. So welcome, Dr. Stevens and Jenny, and we'll turn it over to you. Hi, welcome Jenny and Dr. Stevens. We're looking forward to your presentation and I will turn it over to you now. Welcome.
Sorry, can you hear us?
Yes.
Okay, great. Sorry about that. We were about 2 slides into it, so we'll get started.
Okay.
Thank you and good afternoon. Today we are presenting diabetes and pregnancy. Together we can do it. We have no financial disclosures. I would like to acknowledge my mentors, Dr. Snyder, DeFranco, and Evans at the University of Cincinnati Department of Maternal Fetal Medicine, who taught me diabetes management and permitted use of slides and materials from our yearly department lecture. We also want to acknowledge the MFM diabetes team, who is a resource for you and your patients. Our learning objectives are to describe the diagnostic criteria and types of diabetes treated during pregnancy, discuss the importance of euglycemia preconception through pregnancy to minimize maternal and fetal complications, and explain a multidisciplinary team approach for the treatment of diabetes during pregnancy, including physiologic insulin replacement.
Hi, Dr. Stevens. Can you share your screen with us?
Yes.
Sorry to interrupt you.
Hang on one second. Sorry, guys. There we go. How's that?
Perfect. And then you'll just start from the slideshow from the beginning.
Okay. Slideshow from beginning. There we go.
Perfect.
Okay. All right. Thank you. Sorry. So diabetes is a major global health problem. It affects 415 million people worldwide, accounting for 5 million deaths annually. In the US, 29 million people have diabetes, of which 14.9 million are women. That is 10% of the US population that is anticipated to increase to 33% by 2050. Diabetes costs the US $673 billion annually. 3 to 6% of reproductive age women have pre-gestational diabetes, accounting for 1 to 2% of pregnancy. An additional 7% of women have gestational diabetes, accounting for 86% of diabetes in pregnancy. This includes pre-existing type 1, type 2, gestational diabetes, and glucose intolerance. Regardless of the type, the same universal principles of management apply. Type 1 diabetes is due to autoimmune pancreatic islet beta cell destruction with the primary insulin production defect, resulting in polydipsia, polyuria, and polyphagia, often with weight loss that requires insulin replacement. Type 2 diabetes is from a progressive loss of beta cell insulin secretion and relative end organ insulin resistance linked to obesity. Risk factors for type 2 diabetes are obesity, chronic hypertension, advanced maternal age, metabolic syndrome, and non-white ethnicity. Other types include mature onset of diabetes in the young, cystic fibrosis with pancreatic destruction, and steroid-induced hyperglycemia in women on immunosuppression. Pre-gestational diabetes can be diagnosed by any of these 4 criteria: a hemoglobin A1C greater than or equal to 6.5, a fasting plasma glucose greater than or equal to 126, a 2-hour plasma glucose greater than or equal to 200, or random plasma glucose greater than or equal to 200 in a patient with classic symptoms of hyperglycemia crisis. Diabetes is also a powerful teratogen. The baseline risk of congenital anomalies in the general population is 1 to 2%. This increases 3 to 8-fold with poorly controlled diabetes. In 1981, Miller et al. Found a 22% risk of congenital malformations in women with an A1C greater than or equal to 8.5. Guerin demonstrated a dose-dependent risk with increasing A1C, and Bell showed a 30% risk reduction for every 1% decrease in A1C. The American Association of Clinical Endocrinologists recommends a preconception A1C goal less than 6.5 to mitigate birth defect risk. Many fetal organ systems are affected by diabetic embryopathy, with heart and central nervous system most affected, and caudal regression the hallmark lesion. This is why all women of childbearing age with diabetes should be referred for preconception counseling to optimize control with an A1C less than 6.5. Mothers are higher risk for hypertension, preeclampsia, cesarean delivery, preterm birth, and maternal mortality, even with excellent glycemic control. Miscarriage is as high as 25 to 44% with poor control, but approaches the general population rate with treatment. Fetal and neonatal mortality rates are 3 to 4-fold higher secondary to congenital malformations, respiratory distress, and extreme prematurity. Fetal growth restriction can also occur when associated with other medical comorbidities like chronic hypertension, anomalies, and vasculopathy. Macrosomia can occur with increased adiposity and fat distribution in the torso and chest, as insulin is a growth factor for the developing fetus. Particularly insulin-sensitive tissues, such as subcutaneous fat. Glucose and lipids provide the primary fuel for fetal growth and adipose deposition. In 1991, the National Institute of Child Health and Human Development found that women with a 2-hour postprandial average of 120 have a 20% risk of a macrosomic infant, which increases to a 35% chance for a 2-hour postprandial average of 160. Birth injury also increases with diabetes. The risk of shoulder dystocia is 2 to 4 times higher, with 1/2 of the cases occurring with a normal weight infant from 2.5 to 4 kilos. The risk increases tenfold at greater than or equal to 4,000 grams at the 90th percentile. Therefore, ACOG recommends offering a cesarean section for estimated fetal weight greater than or equal to 4,500 grams, with many providers performing shared decision-making for fetuses greater than or equal to 4,000 grams. This risk increases further for operative deliveries. These neonates are also at a higher risk of many complications. These include respiratory distress syndrome due to decreased surfactant production, polycythemia, as hyperglycemia is a powerful stimulus for erythropoietin production, likely secondary to increased metabolic demand in the large baby who has increased oxygen consumption and relative hypoxia. Hypoglycemia, which untreated can lead to seizures, hyperbilirubinemia, and hypertrophic cardiomyopathy. Always balance your counseling regarding NICU admission with the risk of stillbirth. This is a checklist of pregestational diabetes management to monitor for both micro and macrovascular complications in pregnancy. A dilated eye examination performed by ophthalmology in the first trimester and yearly to screen for diabetic retinopathy and make certain Valsalva is safe. Baseline pregnancy-induced hypertension labs, including a 24-hour urine protein to screen for nephropathy, thyroid testing for other endocrinopathies, an A1C every trimester, and a baseline EKG and maternal echocardiogram if the patient is greater than 35 years of age, has diabetes greater than 10 years, or has hypertension in order to screen for cardiovascular risk. Also remember to recommend a baby aspirin 81 milligrams daily at 12 to 28 weeks to decrease the risk of early preeclampsia and fetal growth restriction. Assess fetal growth monthly at 26, 30, 34, and 38 weeks for delivery planning. Start antenatal fetal testing twice weekly at 32 weeks, or early if poor control. But remember, together we can do it. Diabetes treatment with dietary modification using medical nutritional therapy with meal timing and carbohydrate counting, as well as exercise and physiologic insulin treatment, decreases shoulder dystocia by 60%, macrosomia by 50%, preeclampsia by 20%, cesarean section by 10%, and NICU admission for respiratory distress and hypoglycemia. Use these facts to get the patient to buy into her treatment plan. Empower her with the why so she understands and is willing to do the work. It is very important to provide non-judgmental information, counseling, and hope. Let her know that we have a plan that works. Assess her daily routine and barriers to care. Inform her that her insulin needs will increase with advancing gestational age, secondary to hormonal and metabolic changes of pregnancy, so as to anticipate insulin titration without viewing that as a failure of treatment. This is why target ranges are tighter in pregnancy. Remind the patient that each day is an opportunity for a fresh start. Effective diabetes management takes time and resources. The MFM team can partner with you so your patient can safely deliver close to home. Start planning for her transition to endocrinology early and stress the importance of lactation, birth spacing, and contraception counseling. This will dramatically improve her future and reproductive health. Our certified diabetes educators and nurse practitioners will spend the time to teach the patient medical nutritional therapy. This is a personalized nutritional plan based on the patient's BMI. First, they will do a 24-hour food recall. Then they will show her how to count carbohydrates and instruct her to limit her intake to 40 to 50% carbs daily, with frequent small portions distributed over 3 meals and 2 to 3 snacks. One carbohydrate serving consists of 15 grams. Breakfast should have 2 carbohydrate servings for 30 grams. Lunch and dinner, 3 carbohydrate servings for 45 grams, and snacks of 1 to 2 carbohydrates. We recommend healthy meal choices and avoidance of simple carbohydrates with incorporation of fiber and fat to slow absorption. This is important to prevent hyperglycemia and starvation ketosis, which propagates an erratic blood sugar pattern. We also advise the patient to incorporate moderate exercise after meals, such as walking for 15 to 30 minutes to help manage postprandial blood sugars. There is no consensus on how often to pattern blood sugars in pregnancy. We start with fasting in 1 hour postprandial and then add preprandial if additional correction bolus is needed for pre-meal hyperglycemia. In 1992, Combs et al. Showed that macrosomia is associated with elevated postprandial glucose levels from 29 to 32 weeks during peak fetal growth velocity. Person, Uvina, and the HAPO study all showed that fasting blood sugar increases central adiposity. Both postprandial for macrosomia and fasting for fetal disproportionate growth increases the risk of shoulder dystocia. Therefore, our target blood sugar ranges are tighter in pregnancy, with recommendations for fastings less than 90, 1 hour postprandial less than 120, and an A1C less than 5% for gestational and less than 6% for pre-existing diabetics. Insulin is the gold standard for treatment for diabetes in pregnancy. It does not cross the placenta, but instead reduces maternal blood sugar and thereby transplacental transport of glucose to the fetus. Fetal blood sugar is typically 15 milligrams per deciliter less than maternal. Oral hypoglycemic agents are not well studied in pre-gestational diabetics and should only be considered for those not willing or able to self-administer insulin. All oral agents cross the placenta and worsen neonatal hypoglycemia. Peretti et al. Characterized the diurnal plasma glucose profile in normal third trimester gravidas in 2001. This graph demonstrates the physiology of fasting blood sugar with post-meal elevation with near steady state blood sugars 60 to 110 from 28 to 36 weeks. Our goal in diabetes treatment is to mirror this physiology while avoiding hypo and hyperglycemia. This can be accomplished in type 1 diabetics using a closed loop system with a continuous subcutaneous insulin infusion pump and continuous glucose monitor, or with split dose insulin using long-acting basal and mealtime bolus injections. By using bolus and mealtime basal injections, we can create a similar physiologic curve to the blood sugar seen with endogenous insulin. This is accomplished by setting a scheduled routine of sleep, eating, and activity with the addition of insulin. Each insulin preparation has a characteristic onset, time of peak action, and duration. We can select the appropriate insulin to mimic this curve without insulin stacking or lapses in coverage. These are the preferred short-acting insulins used for mealtime bolus and nighttime basal insulin. These are selected for the patient based on their insurance coverage and glycemic log review. Some patients require only basal insulin. Others need insulin to carbohydrate coverage, while most type 1s also require an insulin sensitivity factor calculation for a correction factor. Most patients do not require more than 4 insulin injections daily. All patients prescribed insulin must also be taught to recognize and treat hypoglycemia, defined as a blood sugar less than 60. We prescribe a glucagon emergency kit and glucose tablets with all insulin prescriptions, and also instruct the patient to keep these along with several small 4-ounce individual juice boxes with them at all times for rapid treatment. The patient needs to know how her hypoglycemia symptoms manifest. Symptoms may be hunger, headache, dizziness, diaphoresis, weakness, fatigue, nausea, tunnel vision, circumoral numbness, confusion, tremors, seizure, coma, or even unresponsiveness. She must not mistake these for the symptoms of hyperemesis or pregnancy, and needs to inform her friends and family what her symptoms are and how to intervene if she is unresponsive. Women with long-standing diabetes often lose their sense of hyperglycemia and require a continuous glucose monitor with a hypoglycemia alert. Hypoglycemia treatment is summarized by the rule of 15s. Strict compliance to these rules will prevent overcorrection and an erratic blood sugar pattern for the day. First, only treat blood sugars less than 60. A 4-ounce box of apple juice is 1 carbohydrate serving of 15 grams. Drinking 1 box will elevate her blood sugars 15 milligrams per deciliter in 15 minutes. She must then recheck every 15 minutes and can only stop when 2 values are greater than 60. If blood sugars are less than 40, give 8 ounces of juice. Stay with the patient and continue the protocol until corrected. 3 glucose tablets are also 1 serving of carbohydrates, so they can be chewed instead of juice. Avoid complex carbohydrates like peanut butter crackers and milk, which are slower to absorb and correct the hypoglycemia. If unresponsive, give glucagon 1 amp, which is 1 milligram in 10 cc's, administered subcutaneous or intramuscular. Recheck the blood sugar in 5 to 10 minutes and repeat as needed. Consider adding D5 normal saline maintenance therapy at 125 mils per hour if blood sugars continue to fall. You can also add an insulin drip once blood sugars are greater than 100 if needed until the patient is responsive, able to eat, and take injections as needed. For type 1 diabetes with an insulin pump, do not feel intimidated. Patients must be proficient at diabetes care before getting an insulin pump and have completed outpatient pump training. They should know their pump management, how to change their infusion sets every 2 to 3 days, how to refill the reservoir, how to give split dose insulin if their pump fails, how to install their continuous glucose monitor, and the buttonology of how to make changes to their insulin regimen. We will help them get their pump supplies and educate them to bring them with them to the hospital. There is also a 1-800 help number on the back of all pumps that you can call 24/7 for immediate assistance. Pumps use a basal rate, insulin to carbohydrate ratio bolus, and insulin sensitivity or correction factor. The bolus wizard will add together the insulin to carbohydrate ratio for the amount of carbs they plan to eat with each meal, and the insulin sensitivity factor to correct any pre-meal elevations based on their glucose target that is preset in the pump. They also know how to set a temporary basal rate for times of fasting, illness, or exercise. When we are making pump changes, we consider the patient's metabolic and physical activity at the time of day. We have the patient make those changes in their pump and read back to verify the correct settings. These are the formulas we use to set up an insulin pump and make adjustments. To the right, you see the typical pump settings for basal rate, correction factor, carb ratio, as well as active insulin. We also program in their target blood sugar ranges. There are several antepartum considerations for pregestational diabetics on your unit. First, avoid terbutaline as it mobilizes glucose from intracellular to extracellular environments and causes hyperglycemia. Next, have a very low suspicion for diabetic ketoacidosis, even if blood sugars are less than 200, particularly if they have an inciting event, such as infection or hyperemesis. And remember, we are always here to help. I have included our algorithm for DKA management. Our nurse practitioners and CDEs will make recommendations for their intrapartum and postpartum management depending on the mode of delivery, the timing of admission, their anticipated NPO status, and breastfeeding, with relaxation of blood sugar targets to fastings less than 120 and 1 hour postprandials less than 180. Now that we have learned the fundamentals of management in pregestational diabetic gravidas, let us switch our attention to gestational diabetes, which occurs in 6 to 7% of all pregnancies and comprises 86% of all diabetes in pregnancy. The same principles will be applied. Gestational diabetes is defined as carbohydrate intolerance with onset or recognition during pregnancy after 20 weeks gestation. Insulin resistance occurs secondary to circulating hormones, including human placenta lactogen, progesterone, growth hormone, cortisol, and prolactin. Risk factors are similar with obesity, advanced maternal age, hypertension, family history of diabetes, non-white ethnicity, and prior macrosomic infant. Gestational diabetics are also at increased risk of preeclampsia from the 6% in the baseline population to 18%. It increases the risk of fetal macrosomia and is also a window into the patient, her offspring, and family's future health, as both her and her child are at an increased risk of developing type 2 diabetes and cardiovascular disease. The motivated patient can apply the tools she learns in pregnancy to improve their health long term. ACOG recommends early screening for at-risk women with physical inactivity, first-degree relative with diabetes, high-risk race, prior macrosomia, previous gestational diabetes, hypertension, elevated cholesterol, polycystic ovarian syndrome, or an A1C greater than 5.7. Obesity and history of cardiovascular risk disease are also risks. They should be tested upon entry to prenatal care and then rescreened at 24 to 28 weeks if negative. This decreases the chance that she will be an undiagnosed pregestational diabetic that is detected later. This is important because these patients often require more insulin secondary to increased insulin resistance. Gestational diabetes is diagnosed in a two-step process. First, the 1 hour 50-gram glucose challenge test is elevated at greater than 130 to 140, depending on your community cutoff. It is diagnosed with a fasting 3 hour 75-gram oral glucose tolerance test. Diagnosis is based on either 2 of 4 elevations or a fasting greater than 126. If the 1 hour screen is greater than 200, do not perform a 3 hour because you have already confirmed the diagnosis of diabetes. Chang et al. In 2009 showed that women with even one abnormal value on 3 hours are at an increased risk of adverse pregnancy outcome. Therefore, we recommend patterning blood sugars 4 times daily for 1 to 2 weeks, or repeating the 3-hour glucola in 4 weeks, depending on gestational age. The 2005 Australian carbohydrate intolerance study in pregnant women showed that gestational diabetes treatment reduces macrosomia from 22 to 13% and preeclampsia from 18 to 12%. The MFMU network likewise demonstrated a reduction in cesarean section and hypertensive disorders. The treatment for gestational diabetes is the same, but time is of the essence. If the patient has elevated blood sugars after diet for 1 to 2 weeks, then do not delay initiation of medication. Again, in a resistant patient, I educate them on why treatment is so important to prevent complications and to optimize their chances for an uncomplicated vaginal delivery and healthy newborn. Historically, insulin was the standard of care due to its safety profile and the fact that it does not cross the placenta. In 2013, ACOG stated that insulin and oral agents are equivalent in efficacy and either can be first-line agents. In 2018, ACOG updated the practice bulletin, saying there is no evidence for increased risk in acute or short-term adverse maternal or neonatal outcomes with glyburide and metformin compared to insulin. For women who decline, cannot safely administer, or cannot afford insulin, metformin is a reasonable alternative choice. We find that the patients referred to us typically require insulin, so we do not delay insulin start. For those of you who use oral hypoglycemic agents, I included a slide for your review. Glyburide is a sulfonylurea that binds beta cells and increases insulin secretion and sensitivity. Its onset is 4 hours and lasts 10 hours. It can cause hypoglycemia and weight gain and should be taken 30 to 60 minutes prior to a meal. To control fasting blood sugars, many providers give glyburide at 10 p.m. The patient must eat a bedtime snack to prevent nighttime hypoglycemia with rebound. The starting dose is 2.5 milligrams, which can be increased to twice daily dosing every 7 days up to a maximum of 20 milligrams daily. It can be used with breastfeeding without causing infant hypoglycemia. Remember to avoid glyburide in patients with a sulfa allergy. Acarbose is a competitive inhibitor of intestinal alpha glucosidases, which delays hydrolysis of complex carbohydrates but does not affect nutrient absorption. It does not cause hypoglycemia. The starting dose is 25 milligrams 3 times daily prior to meals and is titrated up to 25 milligrams per meal until blood glucose targets are achieved, up to a maximum of 300 milligrams daily. It does not cause gastrointestinal distress like metformin. Lastly, metformin inhibits hepatic gluconeogenesis and stimulates glucose uptake at peripheral tissues. It comes in immediate and extended release forms. Many women with polycystic ovarian syndrome and infertility enter pregnancy on this medication and are resistant to stopping it. The maximum dose is 2,000 milligrams daily. Beware, in rare instances, it can cause life-threatening lactic acidosis with renal or hepatic impairment in combination with other drugs, IV contrast, infection, surgery, or hypoxia. We typically discontinue it at 12 weeks gestation. Again, insulin is the mainstay of treatment as it can mimic the physiologic diurnal pattern of daily blood sugars. Remember, if insulin requirements decrease at term or you see more hypoglycemia, then consider placental insufficiency. Think about the possibility of fetal growth restriction or preeclampsia. For gestational diabetes management, we follow ACOG Practice Bulletin 190 from 2018. We start antenatal fetal surveillance at 32 weeks or sooner for poor glycemic control. ACOG does not specify, but we do twice-weekly testing. There is no consensus on fetal testing for diet-controlled gestational diabetes. However, we typically do not perform it unless the patient has other pregnancy comorbidities, such as obesity with a BMI greater than 40. Delivery timing is typically recommended in the 39th week of pregnancy if on medication, but there is no consensus on whether or not expectant management into the 40th week is acceptable for the diet-controlled diabetic. Due to the ARRIVE trial, we recommend 39-week delivery for all gestational diabetics. Again, we complete a growth scan around 38 weeks for delivery planning and reserve the recommendation for cesarean section for macrosomia greater than or equal to 4,500 grams. Delivery should be considered for non-compliant women who have failed or refused inpatient glycemic management between 34 to 36th week due to their inherent stillborn risk. We often offer women inpatient glycemic control for 3 to 5 days prior to delivery if she is agreeable. If the patient will not go inpatient, we do not delay delivery. Lastly, 1/3 of these women will have impaired glucose tolerance or type 2 class B diabetes at their 6-week postpartum 75-gram fasting oral glucose tolerance test. Impaired glucose tolerance is defined as fasting plasma glucose of 100 to 125 or 2-hour of 140 to 199, while diabetes is diagnosed as a fasting plasma glucose greater than or equal to 126 or a 2-hour greater than 200. Again, we counsel them on contraception, breastfeeding, birth spacing 12 to 18 months, and continuation of healthy lifestyle practices and weight loss postpartum. Breastfeeding reduces insulin resistance, hyperlipidemia, and burns an extra 500 calories daily. Hyperglycemia is also transmitted in breast milk, and type 1s can drop low with feeding. This is one of the reasons that blood sugar target ranges are relaxed postpartum. We advise these patients to eat a snack with each feeding and also give mastitis warnings for early evaluation and treatment. This concludes our slides. Thank you for your time, attention, and most importantly, referrals. We are truly appreciative. And now Jenny and I will entertain your questions.